Good afternoon, everyone, and welcome to the ISHLT Cardiology Professional Community Webinar. Our topic today is going to be Beyond Pressure and Flow, Hemodynamic Assessment of Failing Ventricles. My name is Lynn Punnoose, and I'm a transplant cardiologist at Vanderbilt University School of Medicine, and I will be one of the co-moderators of today's session.
Hi, everybody. My name is Sergio Caravita. I'm a cardiologist in Milan and at the University of Bergamo. It is a pleasure for me to be here moderating this very interesting session. So, Lynn?
I'm very pleased to welcome our first speaker, Dr. Mads Andersen from Aarhus University Hospital in Denmark. And his topic today will be the focus on the LV.
Thank you very much, Lynn, for this kind introduction, and thank you for the opportunity to give this presentation. In this session, I will discuss variables pertaining to the left ventricle that might more accurately predict cardiac function and outcomes in cardiogenic shock. So, I'm from Aarhus, Denmark. Denmark is a small blue country up here on top of Germany. I work as a staff cardiologist. I work with pulmonary hypertension, heart failure, and invasive hemodynamics. These are my disclosures. For the agenda today, I will briefly discuss cardiogenic shock, the history and prognostic utility of cardiac power output, called CPO, and a new hemodynamic variable called the aortic pulsatility index, API, or as I like to call it, the PAPI of the LV. So, as you all know, cardiogenic shock is a clinical syndrome that begins with impaired cardiac function, leading to systemic hypoperfusion and results in hemodynamic, neurohormonal, and metabolic changes that progressively worsen without treatment. There are many different clinical classifications for cardiogenic shock. The Society of Cardiovascular Angiography and Intervention, SCAI, has proposed these 5 different stages. These stages are an indication of shock severity, and there's also a significant correlation with shock severity and mortality across clinical subgroups. If we start at the bottom, stage A, that is the patient at risk who are not currently experiencing signs of symptoms of cardiogenic shock, but is at risk for its development, i.e. patient with myocardial infarction, acute deterioration of heart failure, and such. Stage B is the beginning of the cardiogenic shock, where the patient has clinical evidence of hemodynamic instability, could be low blood pressure or tachycardia. And at stage C, the patient has what we call the classic stage of shock, where they have hypoperfusion evidenced by organ dysfunction, meaning that they have an increase in lactate, decrease in urine output, and they require one or more intervention. At stage D, which is the deteriorating shock, the patient, there's a failure of the initial support strategy to restore perfusion, and that is evidenced by worsening hemodynamics or rising lactate. And at the very top, we have the patient in extremis and stage E, which is actual or impending circulatory collapse. And these stages actually show prognostic value, as you see in this paper, which is a figure from the SCAI shock stage consensus document, and it shows short-term mortality as a function of the different stages in different studies. And as evidenced here, the SCAI stages can be used to predict outcomes or to determine the severity of disease on a group level. While the stages may provide valuable insights on a macro level, they might not be specific or nuanced enough to give or to guide clinical decision-making for the individual patient. So there is a demand for a more precise predictive variable to make case-by-case decisions. And we know the heart is a pump, and can we use variables derived from this pump as predictors for clinical outcome in cardiogenic shock? Well, we know the heart, the main function of the heart is to provide hydraulic power or energy, and that is transmitted to the circulation in form of pressure and flow. And the measure of pressure and flow is also power, and we can use that and we can measure that. And if we go back to our days at university and look at the textbooks, we know that the area contained within the pressure volume loop, here called external work, or EW, It represents the work done by the ventricle in ejecting blood during systole and corresponds to the mechanical energy expended by the heart to pump the blood. The area to the left of the pressure volume loop below the end-systolic pressure volume relationship is called potential energy, and that represents the energy stored in the myocardium during isovolumetric contraction and released during isovolumetric relaxation. Essentially, it is the energy that isn't used for pumping blood, and you can view it as wasted. The combined area of the gray areas, potential energy and external work, is called the pressure volume area, and the ratio between the external work, the pressure volume, and the combined pressure volume area is called cardiac efficiency. And we can actually measure the external work, which is in the pressure volume loop, in a simplified formula where we have the difference between mean pressure and filling pressure times stroke volume. So we have a measure of power per beat. And we can actually use that for the different ventricles, where we can calculate the right ventricular external work as the difference between mean pulmonary arterial pressure and right atrial pressure times stroke volume. Correspondingly, for the left ventricle, we can use the difference between mean arterial pressure and wedge pressure times stroke volume. And for the global, or for the heart in total, we can use mean arterial pressure and right atrial pressure, the difference times stroke volume. And note the close resemblance to our stroke work formulas where we only miss a constant. So we also know that one of the determinants of prognosis in heart failure is the mechanical pumping capability of the heart. And back in the early 1980s, Dr. Tan of Birmingham thought about quantifying the mechanical pumping capability in heart failure patients, and he proposed that you can calculate cardiac power as global external work times heart rate. So if you put that into a formula, we now have that the difference in mean arterial pressures and right atrial pressure times the sum of stroke volume and heart rate is essentially cardiac output. So his big problem was that the resting cardiac power output before onset of cardiac disease is unknown. We don't know how the patient were doing before they got ill. So this premorbid value will therefore have to be approximated to the normal resting cardiac power output of an average healthy person. So what he did was that he had an average healthy person with a BP of 120/80, a right atrial pressure of 3, and a cardiac output of 5. And he actually calculated the cardiac power output of this imaginary person. So he would have the mean arterial pressure, which is 93.3 minus 3, the right atrial pressure, times 5 of the cardiac output. And he actually arrived that you had a cardiac power output for an average healthy person of 451. So he averaged the CPO to this number. So the final equation was the mean arterial pressure minus right atrial pressure times cardiac output divided by 451. And what he did was that he took this equation and used it on 63 patients who underwent right heart cath during dopamine stress. Of these 63 patients, 26 of the patients had acute heart failure due to myocardial infarction. The rest were chronic heart failure in New York Heart Association class 3 and 4, and 25, and they had a median ejection fraction of 25%. And what he found that if the maximum cardiac power output of the failing heart during dopamine was below 1, then the likelihood of long-term survival, in this case, that is 12 months, was very small. There was, as the majority of the patients, as you can see here, did not survive. So fast forward to 2004 to this secondary analysis of the SHOCK trial registry. The SHOCK trial registry enrolled 541 patients with cardiogenic shock associated with acute myocardial infarction. Right heart cath was not mandated, so only 75% of the patients had a right heart cath data. But what's more interesting is that this paper used a simplified equation of the cardiac power output where they had removed the right atrial pressure. And I think that's important to notice when we go forward in this talk. In this, in the shock trial registry, 95% of the patient were on pressors, 60% on dobutamine, and 60% had an intra-aortic balloon pump implanted. And what you can see here is that there was a highly correlation between low cardiac output and mortality. And they found in a multivariate analysis that cardiac power output was strongly associated with in-hospital mortality. Like cardiac power output cutoff of 0.53 was found to predict in-hospital mortality. And this study was the claim to fame of cardiac power output, and it has since been shown to offer valuable prognostic information in other cardiogenic shock associated with myocardial infarction population. These are data from the National Cardiogenic Shock Initiative that enrolled 171 patients in 35 centers from 16 to 19. And what you see here is the in-hospital survival as it relates to cardiac power output and the use of inotropes. And what you can see is that if you have a high proportion of if your cardiac power output is high and you have low use of inotropes, you have a very good chance of survival. Whereas if you have a low power output and a lot of inotropes in use, the chance is a lot slimmer. But it also relates to when you use lactate. So if you have high number of cardiac power output, low level of lactate, there's a good chance of survival. Whereas in the opposite, where you have a low cardiac power output and a high lactate, then there's a slimmer chance of survival. So we've seen that cardiac power output carries a lot of prognostic value in this population with the cardiogenic shock due to MI. But what about right atrial pressure? Why isn't that important? And this paper from 2020 by Lynn, he actually looked at the importance of right atrial pressure, and he calculated the cardiac power output using the conventional equation used in the Finger paper, which was the shock trial registry, and from the original TAN, and also the one with including right atrial pressure at two different levels of cardiac output and two different levels of right atrial pressure. And what you can see is the relative impact of right atrial pressure is relevant, especially in patients with low cardiac output and high right atrial pressure, which is very prevalent in the population of cardiogenic shock. In fact, Belkin looked at of the fact what right atrial pressure meant in this sub-analysis from the ESCAPE trial, where the cardiac power output initially was conventionally measured and was not associated with clinical outcomes. But when they looked at patients with right atrial pressure above the median, then cardiac power output calculated with including right atrial pressure was associated with a significantly higher AUC than the cardiac power output without the right atrial pressure. And also suddenly there was a significantly difference in outcome. We have now seen that cardiac power output is highly prognostic in cardiogenic shock associated with acute myocardial infarction. But not all cardiogenic shocks are caused by MI. These are data from more than 1,800 patients from with cardiogenic shock from the Mayo Clinic at Rochester, Minnesota, and they are from 2007 to 2018. And what we see is that cardiogenic shock associated with myocardial infarction is diminishing, and heart failure or cardiogenic shock associated with heart failure is increasing. And now, at this point in time, cardiogenic shock secondary to heart failure is more predominant than cardiogenic shock with MI. So why is this important? Well, this is important because there's a difference in baseline characteristics and also difference in the hospital course. These data are from a single center study that found that cardiogenic shock patients where the cardiogenic shock associated with heart failure were younger, had lower ejection fraction, lower cardiac power output, but had better prognosis compared to cardiogenic shock associated with myocardial infarction. And this supports that despite cardiac power output being an established strong hemodynamic predictor for outcomes in cardiogenic shock associated with MI, it may not have the universal utility when applied to acute decompensations of chronic heart failure. And it could be due to that the cardiogenic shock associated with MI is primarily due to a sudden rapid onset of and loss of a large proportion of the myocardium, where in the cardiogenic shock associated with heart failure, it is typically the culmination of a chronic process, and the presentation is less abrupt compared to the myocardial infarction. And also, if we take a look at the pressure volume curves, we know that heart failure causes new hormonal activation and remodeling, and thus LV dilatation. And this means that if you look at this figure where you on the left side have cardiogenic shock associated with myocardial infarction painted in red, and on the right side you have cardiogenic shock associated with heart failure, what you can see is that due to the remodeling dilatation, the stroke work of the heart failure associated with cardiogenic shock is proportionally lower compared to the total energy than in cardiogenic shock. That means that the cardiac efficiency, which is, if you recall from earlier, that is the ratio between the stroke work, which is within the pressure volume loop, compared with the whole pressure volume area, is lower in chronic heart failure. And this could be one explanation why cardiac power performs less well in cardiogenic shock associated with heart failure. And if we look at the aortic pulsatility index, or the PAPI for the LV, as I call it, that is calculated as the pulse pressure over wedge pressure. It's a novel hemodynamic measurement representing both cardiac filling pressures and contractility. And it compared to cardiac power output, it's aortic pulsatility index more strongly correlates with the degree of decompensation in chronic heart failure. And this figure that you see here at the bottom is a graphical illustration of simulation runs with different states of contractility depicted by the different colors. And what you see here on the left, you have aortic pulsatility index. On the right, you have cardiac power output. And on the y-axis, you have the cardiac efficiency. And what you see is that aortic pulsatility index tracks with cardiac efficiency a lot better than cardiac power output. And especially cardiac power output fails to correlate with the chronic decompensated heart failure states as previous. Belkin, that we saw before, he actually also looked at the aortic pulsatility index in patients with severe heart failure. This is data from 224 patients who underwent a well-renowned drug study. And in the multivariate analysis, higher aortic pulsatility index was strongly associated with freedom from advanced therapy and death, even when adjusted for baseline characteristics and routine right heart catheterization measurements. And they concluded that the aortic pulsatility index is a novel invasive hemodynamic measurement that is associated independently with freedom from advanced therapies or death at a 30-day follow-up. He also had his data on data from the ESCAPE trial, and he looked at the aortic pulsatility index on the 189 patients with both mean arterial pressure and wedge pressure measurements. And they found that the aortic pulsatility index was superior to cardiac power output using the old calculation and cardiac index calculated by FIC. And they found that an aortic pulsatility index above 3 was associated with decreased risk of death and the need for advanced therapies at 6 months. So our take-home message is that cardiac power output is highly prognostic in cardiogenic shock associated with myocardial infarction, especially when combining with other markers of hyperperfusion, for instance, lactate, and it might be a valuable tool for selection of early MCS. Cardiac power output might be less powerful in heart failure or cardiogenic shock due to heart failure, And aortic pulsatility is a promising variable that tracks cardiac efficiency better than CPO, but we need more data. Thank you very much.
Thank you very much, Dr. Andersen, for walking us through those hemodynamic variables. As we're waiting for questions in the chat box, I would like to start off by asking, what do you think the clinical barriers might be to using this clinically as we're managing patients in the hospital? And where do you think we can use variables like CPO and API when we're managing patients on MCS?
Well, I think it's not used due to, it is not all patients have full right heart cath data available. I don't think, I personally use lactate and cardiac index when I look at the patient. I don't, so in one, and also use mean arterial pressure. So in one way I am using it, but I'm not combining it. I think where we can use this the most is, I think, before putting patients on MCS, where we try to stimulate them with inotropes as much as possible and see, is that enough? I also believe we can probably use it when we try to wean patients off MCS, to see if when we reduce the flow from the MCS, maybe we can see how much can the heart of the patient, how much is that possible to create of power? How much power can that create? I believe that I don't know how to interpret cardiac power output in patients on MCS, especially not on ECMO or impeller devices, as when we have the more powerful mechanical circulatory support, we are actually providing the power, not the heart. And we are trying to prognosticate how the heart will do, but we are actually doing a lot of a lot of the cardiac output is provided by us. So CPO will be artificially high. I think we can use it to see is the degree of support given by the MCS, is that good enough? But I don't think we can use it to prognosticate that individual patient who is on ECMO or impeller.
Thank you. I will ask Dr. Caravita if he has questions to ask as well.
Yes, congratulations. It was very clear. Since you stated that PV loops can be viewed as the gold standard and for assessing cardiac function, and you have elegantly showed how CPO may really underestimate cardiac efficiency in heart failure associated with cardiogenic shock. Do you think that the incorporation of a bedside echocardiography may help to correct this error, or might it introduce more noise? Is this a potential solution or no room for it at all?
I think there definitely is room for the echocardiography. I use it on a day-to-day basis. I don't think CPO, especially not without right atrial pressure, is the right way to go in cardiac in heart failure associated cardiogenic shock. I think that I think you definitely would need. I think you need another marker. I think we should go somewhere else. I think we should need aortic pulsatility index might be the right way to go. I don't know. I think I would, in that population, I would use my echo, I would use lactate, and I would use my SATs.
We have a question from the audience. Is CPO in particular helpful in weaning short-term MCS? How would you approach that?
That is a great question. I think that is one to be looked at. I think what you should, I haven't seen data on it. What I would suggest is when you reduce to the minimal flow, you should look at the CPO, and then if that is too low, then I wouldn't wean them. But basically, I think that's what everybody does when they try to wean patients. We do it right now. We use with simultaneous echocardiography and see what is the ventricle, what are the ventricles doing? Are they dilating? Are they coping? Are they reducing? Are they is the EF, is that preserved, or as soon as the load increases? I think it's up to the future. We have to see. We need the data.
I feel like it would be a useful question and something we could get alongside the parameters we're already following, but for some reason I'm not using it as much as I probably ought to be, I think.
I think everybody is using it. They're just not calculating it, because everybody's looking at the mean arterial pressure. Everybody's looking at the output, and they are in the head combining them. But they're just not calculating the number, because if you have to, how do you remember to divide by 451? And it's just difficult.
One other question for you as well, Dr. Andersen. What do you think the role might be for provocative or pharmacologic testing, like leg raise, exercise, or dobutamine on these kinds of variables to assess myocardial reserve and chronic heart failure?
Well, as Dr. Tan showed in the original paper from 1986, I think that is essential, because what we are measuring is what is the reserve mechanical power of the heart. And if we can stimulate it pharmacologically, it is still the heart. So I think that is imperative. I don't think leg raise is the right way to go. I think that's more a fluid status question. But I do think that pharmacological stimulation with dobutamine or other agents is essential.
We will continue to collect questions in the chat box, and we will have more time towards the end, but I will turn it over to Dr. Caravita to introduce our next speaker.
Thank you. So it is my pleasure to introduce Dr. Catherine Kearney, who from the University of New South Wales, who will talk beyond cardiac output and filling pressure with a focus on the right ventricle.
Thank you so much. Just to confirm that you can see my slides there. Great. So thank you very much for the opportunity to present today. I'll be focusing today on the right ventricle and pulmonary arteries, reviewing the clinical applicability of precise hemodynamic variables in the setting of RV failure. I'm obviously an Australian cardiologist and currently the Adult Congenital Heart Disease and Advanced Heart Failure Fellow at Toronto General Hospital. I have no disclosures relevant to this presentation. So by way of brief outline, today I'll introduce this topic with some background on the current guidelines for right ventricular relevant hemodynamic variables in clinical use, and introduce and refresh the background of the RVPA unit and its physiology. Then I'll discuss in more detail pulmonary arterial compliance and RC time, as well as the interplay between the two. As background, we can consider what these familiar tables tell us about the clinical assessment of right ventricular function. Dr. Andersen's already introduced the SkyShock algorithm and classification, and this includes essentially derangement in CVP and cardiac index as it pertains to the RV, the two parameters that are most clearly relevant to assessing RV function in stage B and stage C classification. But there's nothing more specific than this in those recommendations. Intuitively, right ventricular adaptation to loading, pressure or volume is a key determinant of outcomes in pulmonary hypertension, and Reveal 2.0 represents a complete and thorough prognostication tool for PAH patients. Yet the only parameters that make it into this risk prediction tool are a mean right atrial pressure greater than 20 millimeters of mercury or a PVR less than 5 Wood units, to differentiate those with flow-rate right heart failure and those with mild PH, respectively. Surely we could do better than this in terms of utilizing the valuable information obtained from invasive hemodynamic testing in risk profiling our patients. So back to a more basic science kind of background. The fundamental physiological disturbance in pulmonary hypertension is an increase in right ventricular output, regardless of disease etiology. We can model this using the Windkessel model, considering the heart as the pump and the elastic arteries as the reservoir or Windkessel. In general, there are two major factors that modulate the right ventricular afterload. A steady state component influenced by the caliber of the small distal resistive arteries and represented by pulmonary vascular resistance. And the pulsatile component influenced by the elastic properties of the pulmonary arterial tree and represented by pulmonary arterial compliance. Although a complete description of the arterial afterload could be constructed using complex impedance analysis in the frequency domain, a 3-element Windkessel model, more simple measures are required for clinical use. And this may be less relevant in the right ventricle as well. So why pulmonary arterial compliance and RC time? The pulmonary circulation is highly pulsatile, and it's estimated that the pulsatile component of the pulmonary arterial load accounts for about 25% of right ventricular power, as compared to around 10% in the systemic left ventricle aorta-coupled system. Thus, it stands to reason that assessment of pulmonary arterial compliance should be both of physiological and clinical relevance. PVR multiplied by PAC characterizes the decay of the pulmonary arterial pressure in diastole and represents the time constant, or RC time, of the pulmonary circulation. This term can be used interchangeably with the tau of the pulmonary circulation, but I'll refer to it as RC time during this presentation. Focusing on this equation, P0 is the pressure at the onset of the analysis corresponding to time at or immediately after the pulmonary arterial dichrotic notch pressure. And P asymptote is the theoretical pressure at infinite time when the exponential decline has completed. Thus, RC time represents the time necessary for pressure to decrease in value by 36%, 1 over E, of the P0 to P asymptote difference. So it would theoretically take 3 RC times to complete 95% of this pressure change. So how useful is the steady state measure, pulmonary vascular resistance, with which we are all obviously familiar, in prognostication? The 2022 ESC-ERS guidelines recently shifted the goalpost to a PVR greater than 2 Wood units in the diagnostic classification of PH, both precapillary and combined pre- and post-cap pulmonary hypertension. This is on the basis of both the historical understanding of the normal range of pulmonary vascular resistance, as well as epidemiological analyses, including this one from the US VA database. Here, the top Kaplan-Meier curve shows pulmonary artery wedge pressure less than or equal to 15 millimeters of mercury, so precapillary pulmonary hypertension, and the lower one shows post-capillary pulmonary hypertension. These Kaplan-Meier curves show that regardless of wedge pressure, an elevated PVR greater than 2.2 Wood units is associated with worse survival. Refining these interpretations to encompass all abnormal values in terms of pulmonary vascular physiology is an important step to better definition of right ventricular afterload and understanding the RV-PA interaction more completely. Does the spectrum of PVR add further colour to this? Literature shows clear differences in patients with pulmonary hypertension secondary to lung disease at the inflection points of 5 Wood units, as shown here, and 8 Wood units, as shown here, in these Kaplan-Meier curves from an analysis of the European Comparator Registry. However, this is not borne out across the spectrum of pulmonary hypertension, apart from the inclusion of the PVR less than 5 Wood units in REVEAL 2.0. So given the inconsistencies of PVR and our understanding of the importance of pulsatile load for the right ventricle, deriving pulmonary arterial compliance becomes of interest. Most commonly, compliance is calculated using the empirical equation, which is to say stroke volume over pulse pressure. However, this may overestimate compliance as it does not account for blood flow from the pulmonary circulation into the capillary bed during systole. However, it does encompass information about both the distensibility of the total pulmonary circulation, the pulsatile load on the right ventricle, and the function of the right ventricle by the inclusion of stroke volume. A method using flow obtained from phase contrast imaging of the pulmonary artery during simultaneous cardiac MRI and right heart catheterization has also been described. Using waveform analysis of RC time and PVR, a stroke volume independent measure of PAC can be obtained, and I'll discuss this in more detail later. So what is the relevance of pulmonary arterial compliance? These are Kaplan-Meier curves from an interesting analysis of the VA database again, utilizing the stroke volume over pulse pressure PAC calculation, undertaken by Wang et al. In patients with mild pulmonary hypertension, which they defined as a mean pulmonary artery pressure between 19 and 24 millimeters of mercury. This shows an estimated 1-year survival of 22% in those with a PAC less than 3 mils per millimeters of mercury, and 9% in those who had a PAC greater than 3 mils per millimeters of mercury. Significantly, PAC is a calculated measure from stroke volume and pulse pressure performed much better than either variable, stroke volume or pulse pressure alone. The clinical scenario is important in terms of how these different indices might be useful. For example, this data is applicable to a stable patient. Whether these measures are useful in a critical care setting in acute decompensated heart failure is not clear. Of course, we can take some liberty and extend how PAC is used in pulmonary hypertension patients. It's notable that many studies prior to this paper have failed to demonstrate the prognostic value of PAC in pulmonary hypertension. This might seem counterintuitive. The simplest explanation is that when PVR is greater than 5 to 6 Wood units, you're working in the flat part of the PAC versus PVR curve, which you might be able to appreciate by this diagram. In other words, PAC does not change very much in these patients, so trying to prove prognostic value is hard in a multivariable model. On the other hand, those who have PVR that is normal or only mildly elevated, it's on the steep part of the PAC versus PVR curve. I mean, this might be the reason why we're seeing PAC come up as prognostically relevant in this paper. The Wang paper consists of patients, mostly pulmonary hypertension due to left heart disease, and very few had an elevated PVR that we see in PAH patients. So that may partially explain this result. Should this be a treatment goal then across the spectrum of pulmonary hypertension? If PAC is greater than 3 and you have a stroke volume of 70 mils, the pulse pressure needs to be less than 24 millimeters of mercury. Hence, this means the mean pulmonary artery pressure will probably be less than 30 millimeters of mercury. It's an interesting concept that if we utilize PAC greater than 3 as a treatment target, it effectively means that we need to lower mean pulmonary artery pressure below 30 millimeters of mercury, regardless of walk test, BNP, whatever the risk status might say to us. There may be some merit in this, and it's a limitation of risk assessment that we don't aim to decrease load maximally in our patients. Young patients might not be treated aggressively enough because they can still walk 500 meters and be functional class 2, even though the right ventricle is still facing a large load, and this may cause right heart failure with time. Prospective longitudinal studies are needed to determine whether therapy-induced changes in PAC or the attainment of PAC thresholds with treatment are meaningful, but I'm hopeful this will be a future target of research. So the inverse relationship between PVR and PAC is described by a hyperbolic fit, and depicted in this plot, meaning that a rise in PVR is followed by an inverse reduction in PAC and vice versa. And this relationship has been reproduced by numerous groups. Because of this hyperbolic relationship between PVR and PAC, it's been advocated that the product of PVR times PAC, which has units of time, RC time, may remain constant in the pulmonary circulation across the entire range of pulmonary arterial pressure. So this is the equation that I showed you earlier. When pressure and flow are in steady state, the model assumes that the diastolic pulmonary artery pressure decay is well fitted by a single exponential function of time, pressure, with the time constant according to this equation. The RC time characterizes this decay. A constant RC time has really important implications for the quantification of RV afterload. If it's indeed constant, it suggests that PVR and PAC are essentially redundant, and knowledge of one is sufficient to derive value of the other. So is it truly constant? Numerous studies, including the two shown here, have shown that PAC is sensitive to increases in left atrial pressure. With a higher wedge pressure, the PAC to PVR relationship is shifted left and down, as you can see clearly here in analyses from both 2012 and from 2023. Studies also demonstrated changes in RC with heart rate and BMI. Furthermore, reported RC times in the literature have consistently demonstrated significant scatter around them, all of which suggests RC time is unlikely to be a constant, and as an integrated measure of PAC and PVR, has potential to yield significant clinical insight into RVPA physiology. So how might we explore this in a way that does not utilize the empirical equation calculation of PAC that we know may overestimate its true value? Alternative methods of calculating RC time have been described. In fact, the first time it was calculated from the waveform was in 1959. Using the semi-logarithmic method described in this equation. This has been used both in basic and in human models. RC time using the semi-logarithmic method is calculated using the wedge pressure or LVEDP when available as P asymptote, and this allows calculation of PVR as well. PAC is then calculated as RC time over PVR ratio. Introducing further assumptions into physiological analysis can be fraught, however, so our group has developed a technique using phase plane analysis. Phase plane analysis can be performed on graphs with pressure as the y-axis and the time derivative as the x-axis. It allows for greater robustness of results than conventional P versus T fits because pressure and its time derivative are accounted for in the dp/dt versus P fits. This analysis has been used in human hearts to assess the effects of human heart failure on consistency of fit for several different time constants derived from exponential and logistic models of pressure decay. So using this method, my colleague Christina Lee has shown that RC time, calculated from phase plane waveform analysis on routine clinical right heart caths, differs significantly from the empirical equation derived values and yields lower, more physiologic values of RC. So can RC time therefore be used to measure acute changes in left atrial pressure from the PA waveform itself? This is from a cohort of LVAD patients undergoing clinical ramp study with changes in wedge of at least 5 millimeters of mercury between the high and low wedge pressures. RC time reliably shortened with elevations in left atrial pressure. The decrease in RC time with increased left atrial pressure suggests that pulmonary arterial compliance decreases with increased left atrial pressure, independent of the effect on pulmonary vascular resistance. This is significant for the assessment of acute loading conditions on the right ventricle. As an integrated measure of PVR and PAC, accounting for both pulse time and steady state loading, this suggests RC time could be considered as a complete RV afterload assessment parameter. So what if PAC calculated via this method? As you might expect from the shorter RC time, PAC is generally lower than that derived from the empirical equation. And the clinical significance of RC time. So we've performed an analysis of waveforms from the Champion trial and from implanted pulmonary artery pressure monitors. RC time was used alongside other waveform-derived variables to predict outcomes, which is their hospitalization or mortality, and it had a significant contribution to the prediction of clinical events, and more information will be presented about this at a later point. To speak briefly about RV-PA coupling, so obviously right ventricular function is a major determinant of morbidity and mortality for a variety of cardiovascular diseases. Despite its importance, RV function is challenging to characterize and quantify. Two-dimensional imaging modalities, like echocardiography, struggle to negotiate the ventricle's irregular position in the chest and the asymmetry of its geometry. As a result, 2D-based echocardiographic measurements like TAPSE and RV free wall longitudinal strain only characterize contractile function in a single direction or from a particular aspect of the ventricle. More sophisticated modalities like cardiac magnetic resonance imaging or 3D echocardiography, whilst able to overcome some of these limitations, provide predominantly volume-centric descriptions of RV function. Conductance catheter use, both practically and in analysis, has been limited to the research setting. The use of cardiac MRI and 3D echocardiography as cross-sectional imaging in place of cardiac catheters is promising in terms of non-invasive assessment. So non-invasive echocardiography-based techniques have been corroborated in the LV and performed acceptably against invasive RV-PA loops. So echocardiography-based estimates of end-systolic elastance and end-systolic elastance over arterial elastin coupling are highly correlated with conductance catheter measurements, but do not perform well in capturing energetic measurements like stroke work. So this technique relies on a reference pressure time curve constructed by averaging pressure tracings for multiple individuals and may only be valid for specific pathologies because of the nature of RV pressure generation, depending on the underlying disease and the patient substrate. The method also relies on excellent acoustic windows to produce accurate volume time curves and may be particularly challenging in patients who have a history of previous surgery, have a concomitant LVAD. So in conclusion, current guidelines utilize right ventricular filling pressure, CVP, and right atrial pressure and function predominantly for prognostication of the right ventricle. And PVR has a limited role in prognostication, partly due to its incomplete assessment of the RV-PA unit. PAC, as measured by stroke volume over pulse pressure, has a clear prognostication role at lower levels of pulmonary hypertension, and this is potential as a therapeutic target given this. RC time is an integrated measure of PVR and PAC that provides dynamic information using the waveform approach about left atrial pressure as well. And pressure volume loop techniques for clinical assessment of RV-PA coupling remain under development, and hopefully we'll see more of this in the future as well as the techniques become easy to use in the clinical setting. Thank you very much for indulging me talking about pulmonary physiology, and I'm very happy to answer any questions.
Thank you, Dr. Kelly. If there is any question from the audience, please feel to write them on the chat. In the meanwhile, you tried to convince us that pulmonary arterial compliance is probably better than pulmonary vascular resistance, which sounds clear given its greater ability to discriminate early changes in the pulmonary circulation, especially in mild PH or in patients with a mild elevation in left atrial pressure. However, I was wondering, what is your thought about the inability, the potential inability of compliance in predicting outcome after left ventricular assist device implantation, for instance, where pulmonary artery pulsatility index showed better results. Do you think they hold complementary information? Should we prefer one over the other? What's your point on it?
I think the message from most of the invasive only RV techniques is that in isolation nothing is perfect, and that everything needs to be taken in combination. And so I do very strongly believe that they provide complementary information. And unfortunately, I think that there's no easy answers and no ideal parameter, and we have to consider all of those values in context of valvular heart disease and right ventricular dilatation, and what we see in terms of cross-sectional or two-dimensional imaging of right ventricular function. PAPI is reasonable at predicting right ventricular dysfunction after LVAD implantation, but it's not the be all and end all. And I think PAC has an important and potentially complementary role, as you say that.
Thank you.
Very sorry, I missed the start of your question as well. I just dropped out for a second there. I apologize if I drop off.
I had a question for you as well, Dr. Kearney. When it comes to measurements like PA compliance or impedance in the PA system, how can you use them, or would you consider that they can be used to assess responses to pH therapies or differentiate between different kinds of pH?
I think the responsive therapy question is very interesting, and I'm not aware of much, if any, literature on that topic, and I'm hopeful that the fact that pulmonary arterial compliance is becoming more mainstream, that we will hear more about that, especially as, we've always been hopeful that early treatment helps prevent people progressing in pH. It's obviously a very devastating disease. So yes, in terms of therapy, I think that's that it is helpful in terms of guiding. That it will become helpful in terms of guiding. I'm sorry, I've forgotten the first part of your question.
If you think they can eventually be used to differentiate between different kinds or the different groups of pH.
I mean, I think that in terms of the classification of pre-cap, post-cap, and combined pre and post-capillary, we may be able to get hints from the PA waveform, potentially in people with implanted monitors, to see if decompensations are related to worsening pre-cap or post-cap in patients for whom that's relevant, and the CTD group comes to mind there. But I don't think that we have the capacity to do that currently or evidence to support that.
I take advantage for another very short question. You clearly showed how the simplified PAC estimation based on stroke volume and pulse pressure may not provide a precise estimate of true compliance, so that you elegantly showed how by means of PA pressure curve, we may indeed estimate RC time and PAC better. However, is this for prime time? Are we ready to translate it in clinical practice? So you are working a lot on it. Do you think it is feasible to have a rapid translation of these calculations in the cath lab for everyday use?
I mean, in the bigger picture of things, I think it's feasible. Is it ready for prime time? Definitely no, currently. And I think if there may be important measures that are incorporated in the stroke volume over pulse pressure equation that make it more relevant for clinical use than something that is the true compliance, which is, maybe a physiological concept and a less relevant clinical one. Very open to that as a possibility. I don't think we know that yet. And I think some more research in that area will be really interesting. But I do think it'll be feasible to measure RC in the lab with waveform acquisition before we use conductance catheters. That's perhaps what I was thinking.
I have a question for both our speakers and to get your perspectives. So a recent paper by Drs. Grinstein and Dr. Belkin and their colleagues outlined potentially looking at heart failure and classifying it by the presence or absence of ventricular arterial coupling and myocardial reserve, as opposed to classifying how we do currently with the presence or absence of congestion and low or normal cardiac output. How would each of you envision this being applied in initial assessment of a patient with either LV or RV dysfunction?
You go ahead, Kate.
I'll have a go. So I think that would be something that is something that we try to do, particularly for our pulmonary hypertension patients, are the ones that come to mind for me. And I think looking at measures of coupling would be absolutely ideal in trying to really aggressively manage these patients and keep their pressures as low as we, to give us targets to keep their pressures as low as we can to try and give them the best long-term outcome. So in terms of practically doing that, I think for the right ventricle, it is challenging because we need to either do simultaneous MRI and right heart cath or just accept non-simultaneous values. And, there are some assumptions in that are maybe challenging, but I think that is absolutely the type of model that we should be working towards for our PAH patients particularly.
Yeah, but I agree. I think what will happen is that we will start using more advanced imaging. We are now looking at MRI that can actually approximate pressure volume loops from the MRI data. We will have it with the ultra-fast ultrasound echo. I think we will have it again. I think that is where we are moving. I think that all these assessments has a lot of approximation, and we need to show that we are not making wrong calculations. So I'm not sure it's ready for prime time. It also has to be very easy to do. But I think we're getting there, and at a certain point we will be there.
There is another question for both of you. We have talked about the left ventricle and the right ventricle separately, but they are quite interdependent. For instance, if a left ventricle fails, the traction on the right ventricle will be reduced. If right ventricle fails, we may see enhanced interdependence, which may be an issue. So the talk up to now focused on the ventricles as separate entities. Should we be more holistic in our evaluation and take into account also the other ventricle, the one not overtly failing and which seems smarter?
But I think we already do. I think that when we use our echo, we evaluate both ventricles. We also, maybe we don't calculate left ventricular stroke work index and right ventricular stroke work index, but we are in our own mind when we look at the cardiac output and we look at the pressures. We also look at the vena cava, we look at the filling pressures. So I think we also know if we look, instead of looking at cardiogenic shock, you could look at valvular heart disease, and we know if you had it long enough, it will progressively affect the other ventricle. So I think we are on a day-to-day basis. Maybe we are not calling it that, but that is what we do in clinical life.
Yeah, I completely agree. And in the congenital world, it's very prominent. Like we obviously deal with a lot of right-sided heart failure, but if we see any sign of left ventricular failure in our right heart failure patients, it's a huge red flag.
Just a small curiosity, Catherine, do you have any data or any notion about PAC in patients with tricuspid regurgitation? So we see more and more patients with tricuspid regurgitation. We have a lot of interest on it, and it may be a cause or an ancillary cause of right ventricular failure. So may PAC hold significance also in patients with tricuspid regurgitation and low stroke volume, low forward stroke volume?
I mean, I think it's really important to think about that, because partly the other reason to think about that is that the tricuspid regurgitation has an effect on the left atrium, and that has an effect on PAC. I would talk about this in context of Ebstein's, because we see Ebstein's patients. We still, we operate on Ebstein's patients later in life, with very severe TR, very long-standing severe TR, very long-standing severe right heart failure, and I don't think that we have yet the optimal way of knowing who's going to really struggle and who's going to be okay, beyond our general measures of frailty and our preoperative assessment there. We wouldn't operate on people beyond a certain point, but I think that we haven't considered enough the more complex aspects of that physiology in making assessments in right heart failure, and maybe pulmonary arterial compliance is the key there. Maybe it's not, because it is such a stroke volume or cardiac output dependent measure, regardless of whether or not you see it. Like I presented that data on the LVAD patients in like a closed circuit type loop, just by influencing the ramp without changing the volume status. When you influence left atrial pressure by that mechanism, you can alter RC time and PAC. It tells me that it's partly a flow dependent measure as much as it is influenced by the left atrium as well. So I think the complexity of it is not something that we have fully elucidated yet, but I remain hopeful that it may yield some answers in some of the more complex groups of valvular heart disease patients and congenital heart disease patients.
Thank you to both our speakers for a great and engaging session today on hemodynamics and heart failure. Thank you to both Dr. Andersen and Dr. Kearney. Julia has asked me to make a few announcements for our society in general. Our ISHLT elections for this year are from the 29th of September to 13th of October, and there's a call for volunteers to participate, and the deadline for that is October 2nd. Our next ISHLT webinar in anesthesia and critical care professional community is the 19th of October. So we hope to encourage all of you to continue participating, and thank you all for attending today's session.